നമുക്ക് എഴുന്നേറ്റ് നിൽക്കാം. ഒരു നിമിഷം പ്രാർത്ഥിച്ച് ഇന്നത്തെ ക്വസ്റ്റ് തുടങ്ങാം. പിതാവിനും പുത്രനും പരിശുദ്ധനും സ്തുതി ആദ്യമോ എന്നേക്കും തന്നെ. ആമേൻ. ഞങ്ങളെ സ്നേഹിക്കുന്ന ഞങ്ങളുടെ സ്വർഗ്ഗസ്ഥ പിതാവാം ദൈവമേ, ഈ 2025 എന്ന പുതിയ വർഷത്തിനായി നന്ദി. ഈ രണ്ടാമത്തെ വ്യാഴാഴ്ച വീണ്ടും ഞങ്ങൾക്ക് ഇവിടെ കൂടുവാനും ഈ ക്വസ്റ്റിലെ ഭാഗമായി തീരുവാനും ഞങ്ങളെ സഹായിച്ചോർത്ത് നന്ദി അർപ്പിക്കുന്നു. ഇന്ന് ഇത് ലീഡ് ചെയ്യുന്നതായിട്ട് ഡോക്ടർ ജെൻസിയെയും ഡോക്ടർ ഹരികൃഷ്ണനെയും മറ്റ് അതിൽ സഹകരിക്കുന്നതായിട്ടുള്ള എല്ലാ ലീഡേഴ്സിനെയും വന്നിരിക്കുന്ന സ്റ്റുഡൻസിനെയും സ്റ്റാഫിനെയും എല്ലാം അനുഗ്രഹിക്കണമേ. ഇതും ഞങ്ങൾക്കും ഞങ്ങളുടെ ഹോസ്പിറ്റലിനും ഞങ്ങളുടെ ദേശത്തിനും ഞങ്ങളുടെ രാജ്യത്തിനും വരും തലമുറയ്ക്കും ഒരു അനുഗ്രഹമാക്കി തീർക്കണമേ. പ്രാർത്ഥനകളുടനായി നന്ദി. യേശു ക്രിസ്തുവിൻ്റെ വിലയേറിയ നാമത്തിൽ തന്നെ. ആമേൻ. പ്ലീസ് ബി സീറ്റഡ്.
Achan, thank you very much. I just want to make 2 or 3 things very clear. This year we are going for the NAC accreditation, and we don't want anybody to give us any free ride. Unless we are the best, we are not going for the NAC accreditation. One of the very important parts of that is the conduct of CPCs. 10 varshamayitte nammal wait cheyo. At last we are getting our first proper CPC done. And I want to really thank Arun for taking the lead in doing that, for Jensi for having been willing to be the batsman, the dissector, and Hari for the discussion. And we're going to ask many of our senior consultants to follow Jensi's example. ഒരു 2 മാസത്തിൽ ഒരു CPC എങ്കിലും ഉണ്ടെങ്കിൽ it's a great learning for you children, but even for us faculty, we'll really learn a lot through these discussions. So, welcome to the CPC, and I thank the team for making it possible. Arun?
Thank you, sir. So, may I invite the panelists to take the seat. John sir, Mohan sir, Dr. Gio, Dr. Tina, and Dr. Hari can also join. So, Dr. Jensi madam is going to discuss a chronic case of headache, which became a headache for the nephrology department. Headache, he is having headache for almost 1 year, and ultimately patient was in the verge of death, and fortunately a proper diagnosis was made and patient was saved. So, and the diagnosis is blinded. Dr. Jensi madam don't know the diagnosis, so only case is given, and we'll have a very interactive academic discussion during this next 45 minutes. Thank you. Over to you, madam.
Thank you, Arun. Good morning to all of you, and thank you, Arun, for giving me this case. I'll try to do my justice to this case. Let's see how we discuss and reach a diagnosis for this case. So what I would like to do would be to discuss this case as the patient would come to me or to our team. And this patient had lots of encounters with the the team which was treating the patient. And we'll see, and he had problems which was just increasing over a period of time. And we'll pause at every moment and try and see how we can analyze that problem at that point of time. So we'll start with the case. So here is a 60-year-old gentleman who's a diabetic, hypertensive with chronic kidney disease, and he also had a bout of gout, and his renal replacement therapy was started in the form of hemodialysis in March 2022, and they were planning to go ahead with a kidney transplant. So as a part of the workup, coronary angiogram was done, in which he was detected to have a CAD, and he underwent angioplasty. He also was found to have peripheral occlusive vascular disease, and he had a gangrene of the second left toe, and he underwent amputation of that and also underwent peripheral angioplasty. Finally, almost a year after he was initiated on dialysis, he underwent unrelated donor kidney transplantation. So as part of transplantation, he received rabbit antithymocyte globulin at that time. Thereafter, he was on immunosuppressant, steroids, calcineurin inhibitor, tacrolimus, and MMF. He had a good graft function as evidenced by a good renal function. However, after transplant, his insulin requirement had increased and the team had stepped up the insulin. Probably it could have been tacrolimus induced also because we know it causes hyperglycemia. So what we have here is a patient with type 2 diabetes mellitus with documented macro and microvascular complication, systemic hypertension, CKD, status post-transplant with functioning graft on immunosuppression. He seems to have done well for the next 3 months. In May, that is the transplant happened in February, in May, he first time came with a headache. Now the description of the headache is unilateral, left frontal, and what they've said is early morning headache. And it was affecting his daily routine. Some of the symptoms which we usually ask about around the topic of headache seemed to be not there. Fundus, there was no papilledema. Though it was not a typical presentation of migraine, they gave treatment for migraine with the prophylaxis, didn't work. And they had suggested an MRI, but apparently the patient is claustrophobic, so they couldn't do that. So they did a plain CT, which was unremarkable. So now when we see this early morning headache in a diabetic patient, first thing which would come to our mind would be hypoglycemia. And one more history which would have helped in that would be patient feels better after eating the meals. So sure enough, the treating team thought of that and went ahead with continuous glucose monitoring. And sure enough, there was all early morning hypoglycemias. So the action was taken, they decreased the dose of glargine and headache subsided. So at this point, I think we have got over the problem because this headache seemed to be explained by hypoglycemia, and by decreasing the dose of insulin, the patient became asymptomatic. He remained okay for the next 6 months. So now he has come with a right frontal pain and periorbital pain. This seemed to be different. Last time they mentioned left frontal. So it's a different site, character may be different. However, this time also there's no nausea, vomiting, autonomic symptoms, photophobia or local tenderness. There was no papilledema. Because of the hypoglycemia the previous time, they did look at the nocturnal hypoglycemia and 3 a.m. sugar was normal. There was no low recording. This time also, they tried migraine prophylaxis, but it didn't work. They also did a CT-PNS. From the information I have, it has got bilateral sphenoid sinus involvement, bilateral ethmoid, and frontal sinus. But I don't have much detail about the extent of the disease here or whether the bone integrity is lost. I don't know. MRI brain screening was done. Obviously, it was a plain MRI, and there was no abnormality detected at this point. So I've been asked to pause at 3 places where they can discuss. So this would be a place they will go ahead with discussion.
Get the discussion. So, we can start with John, sir.
Thank you. In neurology, we analyze the history and try to arrive at a diagnosis. So the history is very important. This is a 60-year-old gentleman who had onset of headache after about 3 months post-transplant. And it didn't have any features of a primary headache. There was no photophobia. It was non-throbbing. There was no nausea or vomiting, no visual symptoms. And it was unilateral, almost always confined to a specific area at the time. It was initially left side, and I understand subsequently it was on the right side. So, a primary headache is extremely unlikely. So, some of you have attended our NeuroBites 1, the CME on headache. Secondary headache was discussed, and there is some important red flags in the analysis of or arriving at a diagnosis of secondary headache. That is Snoop P10. Snoop 10, sorry. So this gentleman had 3 features of this Snoop P10. He is above the age of 50. It is a persistent, progressing headache, and he is immunocompromised. He is on 3 immunosuppressants, steroids, tacrolimus, and also mycophenolate, and also he is a diabetic. So in such situation, the diagnosis is a secondary headache, most likely an opportunistic infection. So that has to be ruled out by appropriate investigation. So MRI with contrast is the most important investigation at the time. Subsequently, we have to, because it's a focal headache, if that shows some meningeal enhancement, because secondary infections or meningitis also is possible, ICA soil, because immunocompromised patients sometimes can have primary CNS lymphoma or the toxoplasmosis and other things, but usually these are described in HIV infection. So imaging study is very important to arrive at a diagnosis and subsequent analysis. We will discuss more about it later.
Mohan sir.
Yeah, the history is this particular patient is basically immunosuppressant by the disease like diabetics along with an immunosuppressants. So likely to get a secondary infections, either maybe a fungal, it can be a bacterial, it can be a protozoal. So the point is, an history should have been asked, like contact with a cat. That's one of the things you should take, or contact with the water because of the toxoplasmosis or leptospirosis. Chronic meningitis is described in patients with the leptospirosis. So this area, because of the severity of the immunocompromised state, a secondary infection should be thought of, but a primary, that is one of the SOL, space-occupying lesions, like either in the intracranial or a bony secondary infections also to be thought of.
So, Dr. Gio.
So, as nephrologists, as transplant physicians, we usually think about infectious causes whenever we have to, whenever we come across a patient like this. But as already mentioned, the infections, opportunistic infections would be the most important thing. But as nephrologists, we always look for drug levels as well. So we have to think about the immunosuppression that's going on, whether any drugs, one of the drugs is causing the headache also, especially the tacrolimus. Those drugs can also cause headaches. So that also should be considered. The other things at this point, we don't have any other information to go further from this point. Okay.
So to the neurologist and to the physician, don't you need fever? There's absolutely no fever. There's just a headache. So would you go straight into such a...
Systemic manifestations are extremely rare in patients who are immunosuppressed.
Yes, sir. Especially diabetics may not have the classical features of all the textbook presentations with the immunosuppressions.
And Dr. Tina, we have a CT PNS here, and all the sinuses are mildly affected. Is it a normal finding, or should it be a red flag sign, or should we evaluate more into it by seeing this CT? So the radiology reports almost reported as a normal thing.
Good morning. I believe the MRI brain screening was first done, and then on MRI there was sphenoid sinusitis. And for detailed evaluation of that, I think ENT consultation was made. When a patient with this picture comes to us, what we look for is the classical signs of sinusitis, purulent nasal discharge, headache, postnasal discharge. We look for any signs whether we can pick it up. We clinically examine the patient. We do a nasal endoscopy. We try to collect swabs to look whether it is fungal origin, because fungus is usually classical. There is TC material collected in the sinus. And from the very appearance and the very picture, we come to an almost conclusion. But in this case, the CT-PNS, there was only peripheral thickening. The full sinus was not filled. Probably this is in the background of the immunosuppression. The patient did not have the inflammatory signs associated with the fungus. So that is why we waited. We didn't jump and take a biopsy, because we were sure that simply going and opening the sinus without getting a proper representative sample wouldn't help the patient. So sinusitis was in the back of our mind, and that's
One question to the expert panel, or anyone can answer. This patient is having a severe claustrophobia. MRI was practically impossible, and with a lot of difficulty we could get a MRI brain screening with sedation, and that too was a limited study. So this is one big practical difficulty we all face when we order for an MRI claustrophobic patients. So what all are the options available? Maybe John sir can answer, or anyone can answer.
As Dr. Arun mentioned, this is a big problem for us. The only option is to get MRI under anesthesia, because it's important to have a proper evaluation. Without a proper investigation, we cannot go further.
John sir was persistently asking for an MRI, but multiple times we motivated the patient for MRI, but he is not willing, very claustrophobic. And can anyone comment on open MRI, something which is now available at specific places?
Probably,
Do anyone know about an open MRI?
I think radiologists can.
Ruby Hall in Pune, I've got the first, and I'm sure there will be a lot. It's three times the cost, but they say that you can finish the investigation much faster with the throughput. So Ruby Hall in Pune is the place that is available now.
Thank you, sir. So there is an option called an open MRI, but it's not commonly available. Still, we have to go for a sedation and get an MRI. And this patient was sedated, but that is not enough. They may have to go into general anesthesia, actually, to get a proper MRI with contrast. And over to you, Dr. Jensi.
Yeah, thank you. So as Dr. John sir rightly pointed out, if I have to approach a case of headache, first thing is a detailed history. Site, character, radiation, intensity, duration, diurnal variation, postural variation, associated symptoms, aggravating and relieving factors, symptom related to the surrounding structures, otorhino-ophthalmological causes, symptoms suggestive of raised ICT, and drug history. And on examination, I would look locally if there are any signs, like they were mentioning no localized tenderness, especially when you evaluate an elderly person for temporal arthritis, or neurological deficits. Particularly, I will be looking for cranial nerve palsies, anything suggesting raised ICT or meningeal signs. Why am I doing this? I want to categorize them into primary headache and secondary headache. Primary headaches may not need imaging. It's more of a clinical diagnosis. Like in Neurobites, they went into details of that. And we can, just based on the history, categorize into various primary headaches like migraine, cluster, tension, and the other primary headaches. Secondary, mainly it would be related to infections, vascular, trauma, raised CSF pressure or decreased CSF pressure, drug-related, or other causes, like I said, ENT ophthalmological causes. So once we get the history, we can sort of decide whether you want to go ahead with a treatment of a primary headache or whether you want to go ahead and evaluate for various causes of secondary headache. So for this, the red flag signs, we are looking at SNOOP 10. So it's systemic symptoms, whether there's fever or even other systemic symptoms. For example, this may be a headache which may tell you whether it's pheochromocytoma. It will be hypertension and headache. Or a neoplasm. Patient with neoplasm, we never ignore headache. Neurological deficits. Onset is sudden and abrupt. Older age group, pattern change or recent onset, positional, precipitated by sneezing, coughing or exercise, progressive or atypical presentation, papilledema, also pregnancy, painful eye with autonomic features, post-trauma, immune deficiency, and overuse of drugs. So here our patient already have 3 of them, telling that we have to think of secondary headache. He is more than 50. His pattern is changing, the headache pattern is changing, and he is immunosuppressed. So there's enough reason to go ahead with a neuroimaging, and so also probably a CSF study also. And when we see the reasons for imaging in headache by the American College of Radiology, immunocompromised patient, there's a definite indication of going ahead. So your threshold to order MRI for an immunocompromised is very low. So here we are dealing with a headache, probably due to a secondary cause. So March, the following month, there was worsening of headache. So we saw that this time the treatment didn't help. The headache persisted, now it's worsening. Now the systemic symptoms have started coming, fever spikes and disorientation. Patient was admitted, and there was no other systemic complaints like respiratory, GI, or urinary symptoms. There was no neck stiffness or focal neurological deficit, and patient was told to be clinically euvolemic. Now, if you look at SNOOP 10, there is one more thing which has come up. Now there is systemic symptoms. Fever has come up. So, telling us strongly that this could be a secondary headache. So, at this time, patient got admitted and they started the blood workup. And what was standing out was the sodium was low. There was hyponatremia. Arun, you want to go ahead with the further discussion? Okay, sure. So the sodium was low, liver functions were normal. If you look at the complete blood count, there's nothing alarming there. Counts are normal. If you look at the urine, there's no infective process there, but this could be probably the underlying, we know that he is a CKD with nephropathy, so that can explain. Tacrolimus seemed to be in the therapeutic range. The information which I don't have are ESR, which is very important, like especially if you are thinking of an elderly patient with headache, ESR is very important because that may be one clinging point to direct towards a diagnosis of giant cell arthritis. So also, when I'm looking at hyponatremia, I need to know serum osmolality, urine spot sodium, TSH, cortisol, and this patient needs MRI. So I don't have information regarding this. My next question is, why hyponatremia? So when I evaluate a case of hyponatremia, I want to know it's a true hyponatremia. So I look at the osmolality. If it's normal serum osmolality, I should look at if there's hyperlipidemia or hyperproteinemia, which is giving a false hyponatremia, or if there is high serum osmolality due to hyperglycemia and mannitol. Particularly this patient, I saw that the urine sugar 4+, so that should definitely be looked at. And if it's low serum osmolality, we can think of true hyponatremia. Now further, we look at the volume status of the patient, whether it is hypovolemic, euvolemic, or hypervolemic. And they have already mentioned that this patient is euvolemic. So the questions which I would ask would be, does this patient have syndrome of inappropriate ADH secretion? Does he have hypothyroidism? Does he have hypocortisolism? Or is it drug related? So these are the main questions which come to my mind. To say CR, the diagnostic criteria would be serum osmolality less than 275, clinically euvolemic, urine osmolality more than 100, urine spot sodium more than 40, with the normal thyroid function and cortisol function. The patient's renal function should be normal. They should not be on any drugs which should be responsible for that, and no hypokalemia, and there are the supportive criteria. So I just presume with the euvolemia, probably this patient has CR, but I don't have these points to emphatically say it is CR. Again, I shouldn't rest there. I should ask why again. So if it is CR, then why CR? So the main causes would be malignant diseases, pulmonary disorders, disorders of the central nervous system, drugs, and the other causes including inherited. So here, the whole history and the presentation is more pointing towards a CNS disease. So you should think of CNS infections like encephalitis, meningitis, brain abscess, or it could be because of bleeding into the brain like SDH, SAH, stroke, brain tumors, head trauma, hydrocephalus. All this can cause CR. It was told that this patient, probably the headache was managed with paracetamol. They would have been careful with NSAIDs. And 3% saline for the hyponatremia management. MRI brain was attempted multiple times again, but could not be done due to claustrophobia. Patient became symptomatically better. So what I understood here is, here the patient was little disoriented. So maybe that part was taken care of. However, it's mentioned that headache persisted. Here, I don't know if he became afebrile or not. I'm not really sure when they said
Became a febrile.
Okay.
Transiently possible.
transiently. Okay. So was discharged with free water restriction and increased oral intake. This prescription tells me from a neurologist side, this has to be a CR for them to say this prescription. So April, that is just the following month. So we know that his headache is just worsening. So patient again developed worsening of headache, fever spikes. So I was not sure where so like he said, must have been transiently febrile and disoriented. On examination, patient had, now he has for the first time clinical signs also, had mild terminal neck stiffness, but no focal neurological deficit. Patient was clinically euvolemic. So we have 5 months of new onset headache. So from December onwards, it's going on till April. And if it was intermittent or persistent, 2 months of fever. You would like to discuss?
Almost 1 month of fever. Intermittent fever.
Intermittent. So you can go ahead with discussion.
Yes. So this is the second time the patient is getting admitted, and the patient is having fever, neck stiffness, meningeal signs, is now more sick. So something aggressive should be done at this point. Otherwise, we will lose this patient. So neck stiffness means all meningitis, definitely. So we need to act aggressively, arrive at a diagnosis and save the patient. So over to the expert panel. So at this point we are going to do.
Yes. So the imaging study which is available showed some sinusitis. Is it significant? I would like to have the opinion of a radiologist here. In an immunosuppressed patients, the most important etiological diagnosis we are looking for is probably fungal sinusitis. So fungal sinusitis, it's easy to treat earlier as it becomes progress, especially in an immunocompromised patient, it's extremely difficult. Now, sphenoid sinusitis, what are the symptoms? It is a great mimicker. It's very difficult to localize, or even the imaging, routine imaging may miss sphenoid sinusitis. The pain can be very much diffuse. They can have occipital pain, periorbital pain, or even frontal pain. So this gentleman had predominantly frontal pain. The pain will be distributed in V1 and V2 distribution of the trigeminal nerve. So unless you carefully look for, it is likely to miss. Second point is regarding the imaging study. I understand that diffuse mucosal thickening is one of the earliest signs of fungal sinusitis. So it should not be overlooked. We can diagnose probably at the time, as Dr. Tina mentioned. If you go for sinus washings or a biopsy, probably we will be able to diagnose the exact organism. So what are the possible organisms? Fungal, aspergillus and mucor, as we all know. Mucor usually occurs in patients who are having uncontrolled diabetes. This gentleman's blood sugars was reasonably controlled. Mucor usually have a very rapid progression. This was more of an indolent course, very slowly progressive. So most likely this was aspergillus. And now this patient has features of meningitis as well, probably spreading from the sinus. So CSF study is definitely mandatory. And CSF, we should always do very proper examination, all cultures, PCRs, and also corresponding blood sugar is very important. All those things has to be done properly. PCR may be able to help sometimes to identify the organisms, atypical organisms. I do not know what all are available here now regarding fungal. Then we can ask for beta-D-glucan and galactomannan. Probably these were also done, and this may help to identify the organisms. Beta-D-glucan usually will be helpful. It's highly sensitive, but not very specific. But it may help to differentiate with mucor and aspergillus also. One point which I would like to mention, Dr. Jensi mentioned about ESR and giant cell arteritis. All immune-mediated diseases we do not entertain in a patient who is having high dose of immunosuppressions, even though these are all important etiology, like a midline, even the sinusitis, granulomatous lesions like granulomatosis with microangiitis also can be discussed or considered, but in an immunosuppressed patient with high dose of immunosuppression, these are unlikely.
Yeah. Regarding the hyponatremia, this hyponatremia that is probably is an SID age, but the other translocational as well as pseudo-hyponatremia. What is pseudo-hyponatremia means? The patient with a high triglycerides as well as a patient with a multiple myeloma, especially a patient with a hyperparaproteinemia, have pseudo-hyponatremia. The translocation hyponatremia is the high blood sugars with or mannitol disorders. So this patient should also be, we thought of a multiple myeloma also. So the other, just to academic point of view, next is we have to go for the bacterial, fungal, and then galactomannan to be tested, procalcitonin to be done to differentiate whether it's a bacterial or fungal. You can differentiate very well. So along with the ESR is still, it's old, but we take it as a very important test to to look into the different possibilities like tuberculosis, like autoimmune diseases, so chronic infections and all, or malignancy, which all will give an idea whether it is, if it is around beating around 100 or a giant cell arteritis, we can come to a reasonable thought process in that direction. That's also what I wanted to highlight it.
So I have to divide this till the patient had headache, and then after probably March, the patient started having fever. So to the point, till the patient had fever, the patient's main complaint was headache. So I wanted to know what was the tacrolimus. I read in the notes that it was 6 milligram BD, and he was getting diltiazem as well.
TAC levels were normal.
Yeah. So do you think that we could have reduced? Already the patient had a POVD, he had a leg infection previously. Till now we don't have fever, but at that point, before the fever started, do you think that it could be a tacrolimus related headache?
Less likely, because no other features of TAC toxicity, renal functions were stable, no tremors, and also he was sensitized actually. He had done plasmapheresis to undergo the transplantation. Good. So cross-match positivity was there. So reducing the immunosuppression may not would be counterproductive.
But we see occasionally that the headache can happen even without the tacrolimus levels being high. Even subtherapeutic doses, sometimes the patients develop headache, and we reduce the dose and the headache goes away. So maybe that's one differential we could have thought about before the fever started. So once the fever started, did we reduce the immunosuppression?
It was definitely reduced.
Okay.
So we'll have the discussion from Dr. Tina later. So there will be one specific point where Dr. Tina can help us.
Okay. So now with the history and clinical examination, it's suggestive of CNS infection for sure. Now, I would like to, so they have done investigations at this point. So just looking at the CBC, just looking at the total count, we should remember that this is an immunocompromised patient, so everything can be altered. But doesn't look like a frank bacterial process which is happening. It could be mycobacterial, it could be viral, it could be fungal. Viral only catches, the duration is a little prolonged here. You look at the biochemical parameters, renal function seems to be good at this point. Sodium right through this hyponatremia. Now, I'm sure the treating team would have been addressing this and doing corrections gradually, but seem to be persistent. And by now, I think patient is gradually going into a chronic hyponatremia. And if it's CR, we should remember, unless the root cause is identified, we are never going to get over the problem. We also noticed that there's some bit of hypomagnesemia. I just wanted to touch upon the hypomagnesemia here. So it could be because of redistribution, extrarenal or renal losses, decreased intake, drugs, and endocrine disorders. There are two obvious things here for the patient. Calcineurin inhibitors like tacrolimus can cause hypomagnesemia. Syndrome of inappropriate radiate secretion also can cause hypomagnesemia. So if something is explained, I didn't want to discuss about that further. So coming back to this, now we have enough and more reasons to press towards the MRI imaging, now that there is headache with suspected meningitis also along with that. So MRI with contrast followed by LP study was done. I don't have the information about the MRI brain with contrast, but I have the details of the CSF study given here. So let's look at it. So if you look at the CSF analysis, it is colorless clear. Again, it's not turbid, telling us that may not be bacterial. Anything above 5 cells, I would take it abnormal, so it's 260 with a lymphocytic pleocytosis. RBC could have been something attributed to the procedure related. Gram stain didn't pick up any organism, there was no growth. They did look at atypical cells and 3 cytologies were done. It just showed some occasional lymphocytes, there were no malignant cells. Mycobacterium complex, I was told that it was the TrueNAT which was done and was not detected. What I don't have is the CBNAT. In extrapulmonary TB, CBNAT has a better predictability than the TrueNAT. So CBNAT is not there. Liquid culture, midget culture, also I don't have information. CSF protein is elevated. CSF sugar is 149. I don't have the corroborating blood sugar. I don't know if at that point it was high. So I don't know whether it's a low CSF sugar or whether I should just pass it off as normal. And I don't have information regarding CSF ADA also. So now with all the information put together, here is a 60-year-old gentleman, like I said, diabetes with micro and macrovascular complications, CKD status post-transplant with functioning graft on immunosuppressant. I don't have information about the prophylaxis in terms of Septran or antivirals. Presenting with headache, which is gradually worsening with change in character, hyponatremia, probably CR, currently with the syndrome of meningitis in a patient 10 months post-transplant. So when you look at the post-transplant infections, we can broadly divide. There are different ways of classifying, but some may put it as less than 1 month, 1 month to 1 year, more than 1 year. He has crossed the 1 month period anyway, because that is the time when you think of nosocomial infection, donor-derived infection, or recipient-derived infection. Once you go into this state, again we divide it into whether the patient received prophylaxis or not. So another way of looking at it is little more into detail, less than 1 month, 1 to 6 months, and more than 6 months. So he's somewhere here. So, and the possibilities are just wide. It could be various viral, all of them, the opportunistic infections, the fungal, the mycobacterial, the protozoal, helminthic infection. It could be anything at this point. But let's narrow down it to, and so also according to the immunosuppression which he received, the anti-thymocyte globulin will sort of put them at risk for CME, EBV, BK polyoma virus, recombinant listeria infection, UTI, MMF, again a wide array of viral infections, and reactivation of hepatitis B and C, and steroids, herpes. So it's viral, fungal, mycobacterial, parasites, all of them. Steroid will put them at risk, and so also tacrolimus. So this patient is on all of this, so he is at risk for anything. But here we have a CNS syndrome. So we can just narrow it down to post-transplant CNS infection, which could be bacterial, viral, fungal, or parasite. The bacterial infections which are mostly identified are Listeria, Nocardia, and MTB. Whole array of herpes viruses and JC virus, fungal, Aspergillus candida mucormycoccus, and parasite, Toxoplasma gondii. Now, they had gone ahead with the biofire. So we have description of the biofire and some of the blood tests done in terms of serogalactomannan, serum CMV PCR, and BKV DNA PCR. We'll just discuss this along with my discussion of each of this infection. First, let's look at just the bacteria. Listeria usually presents as a meningoencephalitis. Some of the features it can support, but what is against would be it's a very fulminant meningoencephalitis. We don't have time in hand to treat Listeria and sit on it. Besides, this test said that Listeria is not detected. So let's not look at it. Nocardia, usually it's an abscess and less commonly meningoencephalitis. And to say a diagnosis of nocardia, you have to have a histopathological or a culture with a smear diagnosis where you see those filamentous organisms which are gram-positive. And nocardia, usually, what I have seen, they have along with pulmonary or skin manifestation. So if you have a peripheral lesion, you can take the biopsy from there. Here, there's no evidence anywhere else. And nocardia, without a biopsy, we can't identify. So I was told that the diagnosis was made on the basis of MRI, so I wouldn't entertain that diagnosis either. MTB usually presents as meningitis. It can be brain abscess. It can be tuberculoma. He is definitely at risk for this. When we see this, it's CSF. These are the gold standard. You see the AFB, you culture it, or the PCR being positive. But I would just like to pause here a little bit more about the TB meningitis. It's one of the commonest infection, opportunistic infection in a immunocompromised patient. It is lymphocytic predominant pleocytosis, elevated protein. Glucose can be low or normal. And CSF acid phasmia and culture, what we should remember is it's very low sensitivity because it's extrapulmonary. And NAT for CSF by PCR is very specific, but very less sensitive. So you can't rule out a TBM with a negative test. So that is something we should keep in our mind. There are a couple of criteria we can use, Thwaites criteria, Lancet's consensus criteria for TB. So if I look at this man's Thwaites criteria, lower than 4 would be favoring TB against a bacterial, and his is -2. If you look at Lancet's criteria, with imaging it's more than 12, or without imaging 10, his comes around 9. But we don't have this full information which gives a score of 6. We don't have. That is the MRI details. Moving ahead, so from that bacterial, I would still like to entertain the TB. Now looking at the virus, it's the most of the herpes-related virus, CME, HSV, varicella zoster, EBV. Most of them can present as encephalitis or meningoencephalitis, HHV6, HHV7. So what we saw that in the biofire, most of this were ruled out. So we can, and I said the duration was little too long. Some of them are self-limiting. Some of them, they would have become much worse. So it really doesn't fit in. If you look at the JC virus, it's a typically progressive white matter disease. And it can easily be picked up even on a plain MRI. And okay, I think it's one. Thank you. So on a plain MRI, and with contrast, there's hardly any enhancement. Very unlikely. BK virus also, they have actually screened, and it's not moving. So they had screened for BK virus also, which was negative. Now what I don't have here is CSF galactomannan. I don't have the reports. CSF serum galactomannan was shown as negative.
CSF galactomannan is not possible to be done. That's what it is informed by the lab.
Lab, okay. So the other group of infection we should think of is fungus. Here we are thinking of Aspergillus, Mucorales, and Cryptococcus. Now Aspergillus typically presents as abscesses or rhinocerebral infection and meningitis. Now this patient is at high risk for Aspergillus. Now two conditions which would make us think that they could be a CNS Aspergillus is having Aspergillus elsewhere, like because it's an inhaled, the mode of entry is usually inhalation. So if you have a pulmonary aspergillosis and then CNS, yes, I would think of it. Or if you have a sinus aspergillus and then you have a CNS. So with that, CT did mentioning that some sinus involvement, I would like to entertain this. But again, if you look at a definitive diagnosis, it has to be a biopsy and fungal smear and culture. Mucor, I wouldn't want to entertain because it's a very fulminant infection. He wouldn't have been alive without treatment. By now, he would have succumbed if he hadn't identified it in time. Cryptococcus, yes, it is an infection very commonly identified in immunocompromised, but cryptococcal antigen has a very high sensitivity and specificity, and it's negative. They have done in biofire also and separate antigen also. Both are negative. So if that is there, we can just rule it out. So from this group, I would like to entertain the possibility of Aspergillus. Now, a little bit word about the galactomannan and 1,3-beta-D-glucan. Now, galactomannan is more specific for Aspergillus, whereas beta-D-glucan, it can be with Aspergillus, Candida, and Pneumocystis. usually not picked up in mucor and cryptococcus. So that's why sir was saying to differentiate mucor and cryptococcus, mucor and aspergillus, we can use that. But something we should always remember is the false positivity. Just being on hemodialysis, surgical sponges, gauze, surgical patient albumin infusion, beta-lactams, just patient being on piperacillin, tazobactam, give a false positive test. So when you do this test, you should think of what all are the false positives. So also the enteral feeds can interfere with the test. Having tea, milk, pasta, rice, pepper, all this can interfere with the test. So we should very carefully interpret this. So also look at the sensitivity and specificity. So in this patient, 1,3-beta-glucan was not done, so I'll just look at the galactomannan which was done. If you look at the sensitivity, very poor. See, in the blood, it's just 61%, and CSF, even if it was done, it's 69%. But specificity is good. So if we had picked it up, yes, it would have supported, but not picking it up won't rule out diagnosis. Now the last group, protozoa. Toxoplasma is something which you should think of. Again, toxoplasma, the common presentation is a lesion there, a mass lesion with ring enhancement on. The diagnosis is by histopathology or PCR would be the best thing. But in a resource limited setting, what we say is toxo IgG gives us a very good negative predictive value. If toxo IgG is negative, we can reasonably rule out. Here, anyway, toxoplasma screening was not done, and these lesions can be easily picked up even on a plain MRI. Only thing is that ring enhancement will be picked up only on a contrast study. So, from this entire group, I will boil down to MTB from the bacterial group. From the fungal, aspergillus and toxoplasma, I will still keep it there because it was not ruled out yet. Just because he is a post-transplant patient, I don't want to forget about the entire details of non-infectious one. So, a vasculitis with Wegener's, something happening in the sinus and meningitis, yes. Post-transplant lymphoproliferative disorder, lymphomas. But again, it's a mass lesion which should have picked up. Sarcoidosis, very rarely IgG4 related meningitis. I'm just keeping it at very, low possibility, but I shouldn't forget about it entirely. Coming back to what was done for the patient, MRI brain with contrast was done under GA. What I was told was the diagnosis was made on the basis of that. However, a definitive treatment was started. 2 weeks later, patient had a clinical presentation of stroke, and the CT was showing a right MCA tertiary infarct. I was also given an information that prior to this, there was a right internal carotid artery thrombus also. Now, the question is, what can we miss on a plain MRI? I had discussion with few radiologists, but no one was exactly telling me it can be seen, it cannot be seen. So one thing is meningeal enhancement for sure. Very small lesions can be missed on a plain MRI. And anything with vascular, it may be better picked up. If you look at the bony structures, they say always CT is a better thing. Like for example, in the sinus to see if the integrity is lost and if there's an invasion, CT is good. MRI also can pick up. Just looking at the MRI features of few of the things which we just were narrowing it down. Toxo, I said it's mainly a lesion which we are thinking about with typically a ring enhancement on gadolinium scanning. So also MR spectroscopy. Now spectroscopy is something which we use to look at infection versus a neoplasm. But again, it won't tell you which infection. It will just tell you a lead towards we can consider more of an infective process. Looking at TB, it can present as a meningitis, which can be leptomeningitis or pachymeningitis or tuberculoma. Now the leptomeningitis, which is the common presentation, the typical thing is a pronounced, so we say basal exudates. That will sort of point us towards TB. Extension into sylvian fissures. Because in bacterial meningitis, it's always extension over the surfaces of the cerebral hemispheres. They also can have extraaxial tuberculomas, obstructive hydrocephalus, ischemic infarcts. Now, none of these are like, you can't say it is TB, but at least they are pointers towards. Pachymeningitis is a very much rarer presentation, and they can have tuberculoma. The other presentation, like we said, ischemic infarct. Now, there's lots of talk about TB zone versus ischemic zone. TB zone is supplied by medial lenticular striate and thalamoperforating arteries. And the particular area is this area where the head of caudate nucleus, genu, anterior limb of internal capsule, and anterior medial thalamus. As again, ischemic zone. I was looking at various studies, but people have seen that TB patients can have lesions in the ischemic zone and vice versa. So it's not a hardcore thing, but there is something which gives us a suggestion. Now looking at MRI in aspergillus. Now, like I said, it's usually a target-like pattern lesions which we usually see. They can have focal microhemorrhage, mycotic aneurysm, which later can cause a subarachnoid hemorrhage, which is very common in aspergillus. The wide array of thrombosis, embolism, infarction with hemorrhagic transformation is quite typical in aspergillosis, and especially involving basal ganglia, thalamus, and corpus callosum. If there's corpus callosum involvement, it suggests aspergillosis quite a bit. And if there's a lesion, one thing which we see is the ring enhancement is very weak in aspergillus as compared to other lesions. They can have meningitis and ventriculitis, but again, it can be radiographically occult. The other main pointer in aspergillosis is if sinuses are affected. And if sinuses are affected, that could be the most common fungal sinus infection. And if there is intracranial extension, that will sort of tell you, okay, this would be an invasive sinus aspergillosis leading to CNS aspergillosis. But the early changes can be very subtle and it can be missed on an MRI. So we boil down to cerebral angioinvasive aspergillosis with cerebral infarct or TB meningitis with cerebral vasculitis presenting as iris. Now iris, why I thought was after treatment, the patient suddenly had a stroke-like syndrome. I wouldn't think this is an ischemic stroke. I feel this was an infective thrombus, either as part of iris or something which was there earlier, like in aspergillus, which was just progressive. I'll push down toxoplasma down here because there was no, if there's no lesion. And the other clue I just took was the patient 7th, 8th month on treatment, because toxo treatment will finish by 6 weeks to 9 weeks. So the patient wouldn't have been on that. And I pushed down other non-infectious causes also. Now finally, my question is, should I entertain aspergillosis or CNS TB? To say 100% diagnosis, I would say microbiology has the answer. Till then, it is speculation. So what was favoring would be both very common in immunocompromised. Lymphocytic pleocytosis with high protein in both. Evidence of infarction in both. Iris more common in TB, CR more common in TB, but it can be seen in aspergillosis. Sinus involvement, we don't talk about in TB, it's only for aspergillosis. Now, what we don't have is, looking at the microbiological data, we said CSF, PCI, AFB, just because it's negative, we can rule out. ADA is not available, midget culture is not available, CBNAT. So, we are not having any microbiological support there. Here, serum galactomannan negative doesn't rule out the disease. CSF galactomannan is not done, and it was told that it was not available. Beta-D-glucan is not available. Usually when it's an invasive aspergillosis going on, most of the cases start having some cranial nerve involvement. I've been not given any suggestion of any cranial nerve involvement here, and no evidence of any mass lesion either. So my question would be, now we have to depend on the radiology because it is in the brain. So my question would be, what did they see in the MRI? Is it an intracranial extension of an invasive sinus aspergillus? Was there hydrocephalus or ventricular asymmetry? Was the thrombosis infarction in the basal ganglia, thalamus, focal hemorrhage? Or if there was a lesion, was it weak ring enhancing? And in terms of TB, if there's a basal exudate or extension into sylvian fissure, obstructive hydrocephalus, tuberculoma, ischemic infarcts in caudate, genu, anterior limb of internal capsule, and anterior medial thalamus. So both, I don't want to just push away TB, but the sinus thing is the only thing which is sort of pushing it towards aspergillosis. So that is what I would like to leave it at. Yeah,
So
thank you.
the neurology department helped us a lot for this case. And thank you, John sir and Dr. Hari. And may I call upon Dr. Hari to have a radiological discussion with the basis of the clinical inputs from here. So, this is a case where it is very difficult to get a histopathological diagnosis. So we have to strongly rely on the radiological inputs, that to a clinico-radiological correlation, and based on this, we have to take a calculated risk and start the treatment. If it is a histological diagnosis, it is very easy, but based on all the clues, the clinical clues that Dr. Jensi has given, and the radiological inputs, we have to take a calculated risk and start the treatment. The patient is just about to die. If we wait any further, we will lose the patient.
Good morning to all. Thank you for this opportunity. So before going to the images, I just want to mention few points regarding this case. When we see the overall trajectory of this patient or the temporality, we know that it started as a right-sided headache, which later shifted to the left side, and we know that there is some evidence of sinusitis from whatever information is available. So the focality of the headache always suggests it is a secondary headache. We know that it is a sphenoidal sinusitis, which is very well known to produce a midline or a contralateral headache. So that can be easily explained by the paranasal sinus involvement. Second, the headache shifted to the left side, and almost, I think it is around about 1 year, the patient was on an indolent course. So that suggests that something was very contained. It was not becoming very invasive. So what is the potential localization for such a presentation? The patient had a left orbital headache, and the anatomical substrate for that would be most likely a retroorbital pathology. That means adjacent to the sphenoid sinus, it will be a cavernous sinus involvement. So the most plausible anatomical localization would be a cavernous sinus involvement. It is very important to look for the corneal reflex in such cases. That information is not available. Then the patient had a stroke. He had a right MCA stroke, and there's a mention that he had an ICA thrombus. So that again is explainable by the involvement of the cavernous sinus. So we should have a clinico-radiological correlation, anatomical substrate based on the history and clinical examination, and we know the potential structures causing secondary headache, either in the intracranial compartment or the extracranial compartment, on the background of immunosuppression, diabetes, and multiple medications. So we will see the images. Before going this, I just want to show this. Before reading an MRI, we should look at the same site what we thought of. And my anatomical localization is cavernous sinus in this patient. So I just want you all to see this picture, which is very important from the MBBS times itself. The cavernous sinus, bilaterally a trabeculated space consisting of fat, which lies adjacent to the pituitary gland and close to the sphenoid sinus. Through that, internal carotid artery is traversing and multiple cranial nerves are going. This is the course of internal carotid artery. It goes through an S-shaped course and gives off multiple branches like meningohypophyseal trunk, inferolateral trunk. So now we will discuss the images. So, okay, this is the MRI first done in February 2024. That is well before the patient developed a stroke. first thing we should see, this is a plain MRI. We have many limitations. But what we should try is to extract the most important inevitable information. So what can be extracted from this MRI? I just want you all to concentrate on the cavernous sinus region. I think my cursor is visible. So this is the cavernous sinus, sphenoidal sinus on the left side and sphenoidal sinus on the right side. It is very evident from the plain MRI that the sinus is showing a wall lining with some hyperintensity. And I think you remember my last picture from PPT. Here if you can see, this is called a flow void. This is the internal carotid artery, and flowing blood through the internal carotid artery will produce absent signal in a T2 phase MRI. So here, I think everybody can identify that. Yeah. This is called an ICA flow void, which is normal on the left side. But if you look on the right side, that flow void is absent. This is a subtle evidence for an inflammation or loss of proper flow through internal carotid artery. And if you see the wall of the cavernous sinus, we can identify a concavity. This is a lateral wall of the cavernous sinus. But if you compare it to the opposite side, we can see that that concavity is lost, 1. 2, the cavernous sinus is full. So the plain MRI on the onset itself has showed involvement of right cavernous sinus with absent flow void in the right internal carotid artery. And we can see some sphenoidal sinusitis. So only this much information is available from the initial MRI done in February, and immediately after that, one CT paranasal sinus was done to look for sinusitis. So here we can see these are the ethmoidal sinuses and these are the two sphenoidal sinuses. We can clearly see that the right sphenoidal sinus, there is a hyperattenuating lesion over the lining of the sinus. But I want you to concentrate on something else. So just I don't know whether you can appreciate or not, there is a calcified lining on both sides. Because of the age, the patient's internal carotid artery got calcified. We can clearly see the lining. So this is the right internal carotid artery. The wall is calcified, that is what we are seeing, and on the left side. We can see that the right sphenoidal sinus posterior wall has got a bony erosion. This is a very important sign in a plain CT. Paranasal sinus bony erosion is suggestive of an impending invasive fungal sinusitis. So here what we can assume is this bony erosion has produced some sort of dehiscence and some localized inflammation in the right cavernous sinus, and this has produced a stagnation of the blood flow in the right ICA, which has produced a loss of flow void in the right ICA, and thereby promoting the formation of a partial thrombus in the right ICA. So this much information we have obtained from the initial CT paranasal sinus. Now, this is a second MRI done, a proper full sequence MRI done in April 2024. Here, the patient had developed a stroke, left-sided weakness. So we know that it is a right hemispheric stroke. Here, this is a diffusion weighted image. We can see two bright spots, diffusion hyperintensity, one involving the optic chiasma and paraventricular region, and the other involving the superior hippocampus and maybe encroaching to the posterior lentiform nucleus. So this is the classical territory for a right anterior choroidal artery. Anterior choroidal artery is a branch from the right ICA before bifurcation into MCA. and after the origin of the posterior communicating artery. So the patient has developed a right anterior choroidal artery syndrome which has produced a small infarct. So we will keep it like that. Now I want you to again look at the T2 MRI for this patient, the plain MRI. You may be remembering the old T2 MRI, and on comparing you can see the bilateral sphenoid sinus involvement. That means the sinusitis has progressed, and we can clearly see the ICA fluid is absent again, and it has produced some irregular intensity within the lumen of the blood vessel. Now this is a proper sequence MRI, and we will see the contrast study. Yeah, this is a post-contrast T1 imaging, which is very clear on the findings. This is the cavernous sinus region and sphenoidal sinus. The both sphenoidal sinus shows enhancement of the wall, and if you carefully look into the cavernous sinus, this is the left cavernous sinus, right cavernous sinus. We can clearly see an asymmetry. This normally cavernous sinus will enhancement after contrast administration. So we cannot tell that enhancement in the cavernous sinus is pathological. What we should look for is the subtle asymmetry, which we will miss if we won't carefully look. Second finding, there is an adjacent anterior temporal dural inflammation. This cavernous sinus inflammation has encroached onto the temporal dura. We can clearly see there is a focal pachymeningitis here. This has not produced a fulminant meningitis. This has only produced a localized cavernous sinus thrombosis with ICA thrombus along with a focal pachymeningitis. So with this MRI, we can conclude that the patient has a right, probably a fungal. There is no definite radiological evidence to tell that it is fungus, because normally in an advanced fungal sinusitis, the sequences will be hypointense signal will be seen on T2 and T1, because the fungus will produce some paramagnetic ions during the metabolism and will produce hypointensities in the MRI sequence. But based on the background clinical history and the findings, angioinvasion is there, although it is not very florid. We can conclude that it is a fungus, and the CTPNS also showed a bony erosion. So I just want to show the last CTPNS, which was done recently in December. So just look at this cavernous sinus region. You can clearly see bilateral ICS coursing through, but we can see the newborn formation on the posterior wall of the sphenoid sinus, which indirectly tells us that the patient may be responding, and the local milieu of the sinus inflammation and ICA inflammation might be on the resolving side. So what are the potential etiologies for cavernous sinus involvement? It has got a wide range of spectrum: neoplastic, vascular, inflammatory, and other benign conditions like cystic lesions, arachnoid cyst, epidermoid cyst, and all. And the neoplastic lesions are virtually out. The MRI picture is characteristic for them, and they have got an epicenter. Here the epicenter is sinus. So we know that it is a sinusitis progressing to a cavernous sinus involvement with ICA thrombus. So this inflammation has produced a partial thrombus. Fungal sinusitis can be invasive fungal sinusitis. It can be acute invasive, chronic invasive, granulomatous. Non-invasive can be allergic aspergillosis and a fungal ball or mycetoma. So based on the imaging and available history, my diagnosis, there is a florid immunosuppression background, multiple medications, bony erosion, probable angioinvasion. I won't tell it as a definite angioinvasion because the intracranial vasculature is fairly normal, and only an ICA partial thrombus has produced a minor stroke. ICA partial thrombosis, right anterior choroidal artery stroke, cavernous sinus involvement, and a focal pachymeningitis with a sphenoidal sinusitis. So this may be an acute on chronic presentation, like an indolent sinus infection, which has apparently progressed at some point. So we should know the diabetic status, whether there was any recent history of uncontrolled blood sugar level or any change in the immunosuppressant level at some point and definitely needs a tissue diagnosis, which could be difficult in this case because of its proximity to a major carotid vessel. So we can conclude that it may be likely aspergillus. Some additional sequences which might be helpful are a TOF angiogram, which if would have helped to show the right ICS stenosis. So that would have been an ideal addition to this MRI sequencing, and a vessel wall imaging which can help to show vasculitis or inflammation of the ICA wall. So we should do a follow-up imaging to look for resolution of this pathology, but we can conclude that based on the newborn formation that may be improving. So an MRI with the contrast can be repeated at some stage to decide on tapering the treatment. So thank you, that's all.
Thank you very much. So based on the...
One more thing I just want to add, in the CSF, we can do another test called pan-fungal antigen. So that is available widely. That will help us to determine some species of aspergillus, some species of mucor. So pan-fungal antigen may be done in this patient. I think that may be positive also. Blood sugar level is not available. That's also
It's normal.
Yeah. Thank you.
So, thank you very much. So based on the radiological inputs, clinical radiological correlation, and as the biopsy is very, very difficult, so patient is very sick at that time, so it develops, and later patient develops a left hemiplegia, left MC at stroke after 2 weeks after the last MRI. At that time we only took a CT, and patient was sick, hemiplegic, hyponatremic, very fever is coming, and it is practically not possible to go for a general anesthesia, intubate the patient to get and go inside the venous sinus. As per the Dr. Tina, the patient may cause the life of the patient. So take the risk, believe the clinical radiological correlations, the clinical and the radiological, and start the treatment, a calculated risk. So it could be very likely an invasive fungal infection. Mucor is very less likely because it is a very aggressive thing. Patient will not last this much. So this is an indolent invasive fungal, very likely. So if it is an aspergillus, the most easiest treatment will be a voriconazole. And the voriconazole, the problem with for us is it has got interaction with the tacrolimus. So it inhibits the metabolism of the tacrolimus. The tacrolimus levels will go very sky high. The tacrolimus toxicity can happen. So there will be much higher immunosuppression and the fungus can grow more rapidly. So we have to do a therapeutic drug monitoring, lower the dose of tacrolimus. So patient was on 6 milligram tacrolimus 2 times, so 12 milligram. So we have to brought it down to 0.5 milligram 2 times. That is, one patient is only on 1 milligram tacrolimus, from 12 milligram 1 milligram with voriconazole. So we have got 2 preparations, IV voriconazole and oral voriconazole. The patient was started on oral voriconazole, 200 milligram 2 times, and we did the therapeutic drug monitoring, adjusted the tacrolimus dose. And fortunately, I will say, after 2 weeks, patient almost recovered, no fever, no headache. We are struggling fighting the hyponatremia. We are giving 200 to 300 ml of 3% saline daily to maintain the sodium levels, but the sodium is not going high. This is because the root cause for the SIADH is not corrected. That is a invasive fungal infection. After starting the voriconazole, after 2 weeks, sodium levels normalized. Now it is almost 8 months. The patient is still on oral voriconazole. So initially patient was on 200 milligram 2 times, and for the last 2 months we have reduced it into OD dose, 200 milligram OD, so that we adjusted the tacrolimus dose. So for the past 8 months the patient is on oral voriconazole. Voriconazole can cause hepatotoxicity, so we are closely monitoring the LFT, and patient is very normal now. He is walking, he has got some residual weakness, but he is walking, he is doing all the activities. He owns a lot of properties and real estate in Kayangulam area. He goes to all his shops, collects the rent, and he is very, very happy. From the point, the family, everyone thought that he is going to die. Even a lot of people came here to pray at that time for the patient. So it is a calculated risk based on the clinical radiological correlation, and I specifically want to thank the neurology department and also Dr. Jensi for the excellent presentation, who take up the challenge without knowing the diagnosis. Thank you very much.
Arun, yeah, good presentation, good case. I appreciate all of you. Next, I wanted to contribute to that. In specific galactomane and specific to aspergillosis, IgM and IgG is available in the laboratory. So you can send that and reconfirm again as a clinical case regarding the galactomannan specific to aspergillosis.
Can you?
Thank you very much. That was an excellent clinico-pathological discussion, which is akin to the almost New England Journal of Medicine clinical methods. There is one question that I have that is to the nephrologist actually. Tacrolimus by itself can produce aseptic meningitis, can produce symptoms of hyponatremia, hypomagnesemia, and all these features that you have described can be produced by tacrolimus by itself. The very fact that you have reduced it from its original 12 milligrams to 0.5, could that be partly the cause of improvement? Of course, I agree with the radiologist, the subtle changes that have occurred in the cavernous sinus region, the loss of integrity of its lateral wall, would also profess that it could be aspergillus. Again, galactomannan for angioinvasive aspergillosis is often positive, and here it is classically negative. Should you also be considering this? And of course, I looked to see if there was any evidence of press as a result of tacrolimus, and I don't see it. But that is one of the things that we should also consider. Thank you.
So for the tacrolimus, we monitored the dose. So when the patient was on 12 milligram per day, the level was around 6. And even with 0.5 milligram 2 times, the level is still around 6 tactile blood levels. So level is same in the previously and now. The level is the dose is brought down because of the interaction with the voriconazole. So with the same levels, it may be less likely. And madam has told the sensitivity for picking up invasive aspergillosis with galactomannan, the sensitivity is only nearly 60%. So we are almost 65. We are almost running out of time, 9:30.
Just one question. Thank you very much for that excellent presentation. Very interesting, very informative. I have one basic question. Finally, the diagnosis was made by radiological evaluation, MRI contrast, that was done under general anesthesia. Could this diagnosis have made when he presented earlier, that was in December 2023, where MRI with contrast, he was very claustrophobic. So couldn't GA have been was there any contraindication to the administration of general anesthesia during that visit? Could we have avoided this journey? So much of, this is a very basic question.
Relatively stable patient with only headache. So family will never allow to undergo a GA and do a MRI. John sir has motivated the patient multiple times. I have motivated the patient multiple times for MRI. And also at that time, it was not that invasive. The initial, there was a progression over the last 2 months from March to April. So at that time, it may not be that much invasive. So may not be picked up like how it is now. And also reluctance from the family prevented from doing an MRI.
Because there was almost more than 5 months, gap between the first presentation and final diagnosis. That's why.
Claustrophobia was the issue at this time. So because of the, as we are moving at 9:30, we have to wind up. I'm going to hand over the mic to our dear GC sir for winding up notes.
Thank you so much. This is absolutely fantastic. The beginning of great things. Next one will be from Dr. Luke Matthew, and after that from Philip Finney. Okay, start working out something like this for the NAGM type of thing. Thank you. Thanks a lot, panelists. Thank you, Jency. Thanks, Arun. Hari.
Thank you. Thank you very much.